Recording in progress.
This meeting is being recorded.
Good evening, friends and colleagues. Welcome on board for the third International Speaker Program of Society for Eczema Studies. I welcome you all on behalf of SES or Society for Eczema Studies. It is my proud privilege to welcome Professor Phyllis Plaf from Amsterdam. Welcome, Phyllis, on board. And
Thank you so much, Professor Dar.
Thank you very much. And also, Dr. Annelie Mosters from Amsterdam. Welcome on board, Annelie.
Thank you.
I take this opportunity to welcome my, Indian colleagues. Professor Kiran Godse. Welcome on board, Kiran.
Namaste.
Professor Manjunath Sena. Welcome on board. And Dr. Pradeep Srivastava. Welcome on board.
Thank you, sir. Thank you.
So before we start our scientific program with analyst presentation, I would like to introduce Society for Eczema Studies very briefly because our time is very short. I want the maximum time is spent on presentation followed by panel discussion. Society for, let me share my presentation. Is it visible clearly?
Yes,
Can
sir.
you make it full screen, sir?
It is full screen. It is full screen.
The PPT, sir, down, it is there, no? Yes,
Okay, just a minute. Is it visible now, full screen?
Please share the entire screen.
Just a minute.
Sir, entire screen. Yes, sir. Now full screen.
Now full screen?
No, sir.
Yeah. Now it
Yes,
is full.
sir.
Yes.
Yeah.
Yeah.
Society for Eczema Studies is the first society of its kind from India and entire Southeast Asia, though there are multiple societies, 8 to 9 societies across the world. This is the society which is dedicated to the cause of eczema, education, research, data collection, as well as holding conferences, webinars like this, and through this educating the people and contributing to the subject of eczema from this part of the globe, and collaborate with international societies, the various international societies like International Eczema Council, SPIN. We have the president of SPIN, Professor Phyllis, Plaf with us. He has been very successful president of the society. So, like this type of societies, our motto is to collaborate with them and do some solid work for the cause of eczema. This is the website of the society. And as far as today's topic is concerned, it's extremely interesting topic and up-to-date topic, I must say. Atopic dermatitis, the status of atopic dermatitis in the era of COVID. I'm sure that it would interest all our, viewers who have logged in. And this is the thesis of Dr. Annelie H. Mosters, who is doing PhD, who is the speaker today, in the Department of Dermatology at Amsterdam University Medical Centers under Professor Phyllis Plaf, who is the chief dermatologist at Amsterdam University and professor and head, and also the president of SPIN. I had the good fortune to be there in the first week of July to participate in the annual Congress, 7th annual Congress, and it was a grand success, I must tell. It was a huge success. Please give a very big hand to Professor Phyllis Plaf. She is a big name in the field. She is a legend in the field of atopic dermatitis globally. She is a very active member of International Eczema Council also. And this particular, subject, atopic dermatitis in COVID era, This is one of the largest survey carried out by few persons, Professor Files, Professor Kirsten Floor, and many across the globe. And Dr. Anneli Musters has very rightly taken up this subject today to highlight. She is also a part of this big project. I, in my own humble way, have contributed little bit along with few of my other colleagues. Coming to next panelist, Professor Kiran Godse is the professor and head of dermatology, D.Y. Patil Medical College, Mumbai. Actually, he is an urticaria man. He is a global urticaria man from India, has done huge work in urticaria, but also he has done good work in atopic dermatitis, has got keen interest in atopic dermatitis and experience in the field. Welcome, Dr. Kiran. Professor Manjunath Sena is the moderator for today's session. He is a professor and head of Inepoya Medical College, Mangalore, a very academic person, as a dynamic man with lot of research ideas, is the vice president of Society for Eczema Studies. Today he will be moderating. Welcome, Dr. Manjunath. The list, Dr. P.K. Srivastava is a consultant at Allahabad, UP. He is also a very active member of Society for Eczema Studies. All are very active members, Dr. Kiran, Dr. Manjunath Sena, P.K. Srivastava. And with this, I thank you all for joining today. And now it is turn of Dr. Anneli to start her presentation. I am stopping my presentation. Over to you, Anneli. The platform is yours now.
Thank you, Sandipan. Is it clear like this?
Yes.
Okay, perfect.
This is perfect.
Okay. Well, good evening, everyone. Thank you, Sandipan, for your introduction. It's a great honor to be here to talk about atopic dermatitis and COVID-19. We have been battling with COVID since early 2020, as you all know. And in response, we set up the Secure AD registry. In today's talk, I will capture the results of this global registry study. So these are my disclosures. So what about COVID risk and complications in atopic dermatitis patients? As you may know, both bacterial and viral infections are more common in AD patients. And a recent epidemiological study demonstrated that many inflammatory skin diseases, including atopic dermatitis, were associated with higher risk of COVID-19, even after controlling for confounding variables. Another factor to consider is that AD patients are often treated with systemic immunomodulatory treatments, such as systemic corticosteroids, non-steroidal immunosuppressants, such as cyclosporin and methotrexate, but also newer treatments like biologics and JAK inhibitors. Different mechanisms of actions and level of immunosuppression may impart variable risk of a serious infection. On the other hand, some degree of immunomodulation may have a beneficial effect on the course of COVID-19, and targeting of specific immune pathways could reduce the development of a hyperinflammatory state seen in severe COVID. Dupilumab targets interleukin-4 and interleukin-13, and as emerging evidence suggests that expression of Th2 cytokines may be increased during COVID-19, dupilumab may have a protective effect in the context of COVID infection. The safety profile of dupilumab has been established from several clinical trials and case series during the COVID pandemic. Right at the start of the pandemic, we were faced with important questions like, do systemic immunomodulatory treatments influence outcomes of COVID-19 in patients with AD? And do they lead to a more severe course or even death? And do patients on dupilumab or other novel systemics fare better than those on conventional systemic treatments? To answer some of these questions, we set up a registry to investigate COVID-19 outcomes in patients with AD treated with or without systemic immunomodulatory treatments. Here is the Secure AD team, consisting of colleagues from the Netherlands, the UK, Ireland, Canada, Japan, Taiwan, and Spain. Secure AD stands for Surveillance Epidemiology of Coronavirus under Research Exclusion for Atopic Dermatitis and was launched in April 2020, right at the start of the pandemic. Anonymized data were collected using a web-based case report form. And with regard to the eligibility criteria, AD patients have to have had proven or at least high suspicion of COVID, and patients of any age treated with any systemic or topical treatments were eligible. We asked physicians to wait with entry until the patient was fully recovered, and statistical analysis were performed using R. So between April 2nd, 2020 and October 31st, 2021, we recruited 452 patients from 27 countries, of whom 10 patients were excluded from further analysis due to the fact that they were treated with immunosuppressive drugs for other indications than atopic dermatitis. Here you can see the demographics of the recruited patients, and we see that patients had a mean age of 36 and a mean BMI of 24, and there's an equal sex distribution. In the beginning of the pandemic, COVID tests were not broadly available. However, still 69% of our patients had a PCR-based COVID diagnosis. And we can see that the majority of patients are of white ethnicity, and most patients were recruited from Italy, followed by India, the UK, and the rest of Europe. So here you can see the number of patients per treatment group. The majority of patients were treated with dupilumab, followed by topical treatment only. And we can also see we have a group of 14 patients on combination treatment, of whom most received systemic combined with steroids. About 12% of patients visited emergency departments, 6% were hospitalized, and only a few patients required intensive care or ventilation. Fortunately, no deaths were captured in our registry so far. Because ICU admission rates were low, we took hospitalization as main adverse COVID outcome. When we look at hospitalization rates by treatment group, we see that patients treated with dupilumab were unlikely to be hospitalized. Hospitalization rates in patients on dupilumab were even significantly lower than patients on topical treatments. Patients on topical treatments, patients on topical treatment had higher odds of hospitalization compared to patients on dupilumab. However, we also see at the bar on the bottom bar, and it's quite striking that almost 36% of patients in the combination treatment group were hospitalized. To further explore the significant differences in the rate of hospitalization between single agent treatments, as identified on the previous slide, a multivariable logistic regression model was fitted, adjusting for confounding variables like age, sex, ethnicity, and comorbidity score. Here you can see the adjusted odds ratio for hospitalization of different monotherapy treatment groups compared to dupilumab. And this figure shows that patients on topical treatments have higher risk of hospitalization compared to dupilumab monotherapy, even after adjusting for confounding variables like age, sex, ethnicity, and comorbidity score. To further explore the high rates of hospitalization in patients treated with combined systemic treatments, as I've shown earlier, we performed a subgroup analysis, including patients treated with non-steroidal immunosuppressive monotherapy, systemic corticosteroids, and combination systemic treatments, not including or including corticosteroids. And we see that highest rates of hospitalization were observed in patients treated with combination systemic treatments, and including systemic corticosteroids. So, combinations including corticosteroids. So we further investigated this finding using multivariable logistic regression, again adjusted for the confounding variables. And this figure shows the adjusted odds ratio for hospitalization in different treatment groups compared to non-steroidal immunosuppressive monotherapy. Overall, we see that patients on combination systemic therapy have higher odds of hospitalization than patients on non-steroidal immunosuppressive monotherapy, even after adjusting for confounding variables. So, strengths of our studies include a geographically and ethnically diverse sample of patients and a detailed description of the COVID-19 disease course in patients with EE. As I described earlier, we included patients from 27 countries all around the world. However, an important limitation of our study is the absence of vaccination status in the included patients. However, one aspect of our analysis, which reassures us of the validity of our findings, despite inability to control for vaccination status, is that our adjusted analysis controlled for age, sex, BMI, and comorbidity status, which in many countries were the variables used to prioritize patients for vaccination. Therefore, it is likely that we already have, at least partially, adjusted for the likelihood of vaccination by proxy in our adjusted analysis. Another limitation is the selection bias in our study. Physicians may be more likely to report patients on systemic therapy or patients with more severe COVID-19 infections. The absence of any reported deaths in our registry is therefore reassuring. And finally, because of the relatively small numbers of patients on individual treatments, some analysis had to stay at aggregate level. So that brings me to the conclusion of our study. And overall, the risk of COVID-19 complication appears to be low in patients with atopic dermatitis, even when treated with systemic immunomodulatory treatments. Moreover, dupilumab monotherapy was associated with lower odds of hospitalization than other therapies. Combination systemic treatment, especially combinations including corticosteroids, were associated with the highest risk of severe COVID-19. Other population-based study designs may be more suitable to answer other important questions. For example, is the overall risk of COVID-19 in AD patients higher or lower compared to healthy controls? I would like to thank our partner organizations and advisory committee, and we plan to conduct analysis with other COVID inflammatory disease registries in the future. The Secure AD study is still ongoing and we still work on registrations. And I'm also happy to inform you that our first paper has been accepted for publication in the European Journal of Dermatology and Venereology last month, so you can read about the results I briefly discussed in this presentation today, soon. Many thanks for listening, and I'm happy to take any questions.
Thank you very much, Dr. Anneli, for your wonderful deliberation on a very important topic. I must say the hot topic these days. And, for a chronic disease known for more than 6 decades, something which has happened over last couple of years. What is the effect of the disease on that old disease, which is known for more than 6 decades? And a lot of questions about immunosuppressive use and other things. All these have been, addressed very nicely. And the Secure AD registry is a very important registry globally. It has got a lot of importance, and the very fact that the first paper of ours has been, accepted and published in, EADV, JAEDV, Journal of European Academy of Dermatology Journal, talks volumes about the importance of the subject. Thank you very much for your wonderful presentation. Now it is my time to invite the moderator, Dr. Manjunath Senai. Manjunath, you can just, unmute yourself. And the panelist, Professor Pairis, you can unmute yourself. Pairis, I can see that Professor Kiran Godse and Pradeep are already there, unmuted. So please carry on. It is all yours, Manjunath.
Yes.
This platform is yours, so I shall be remaining quiet, for the time being.
Yeah. Hello, sir. Thank you so much, sir, providing us an opportunity to learn more on atopic dermatitis, and especially as you mentioned, this is a topic which is so important because we believe that pandemic is getting over, but the pandemic doesn't think so. It doesn't seem to be thinking so. So I think this is very relevant, and we have plenty to learn. Thank you, panelists, for being a part of this. And so I just quickly have a couple of slides to highlight what's happening in the COVID era. So this is the number of cases which have been reported worldwide, almost 602 million and 6.4 million deaths. And when it comes to India, it's around 4 crores. We call it as 4 crores. That's about 444 million and 5.2 million deaths. And this is exactly what I was talking. We think we are done with the pandemic, but the pandemic is not done with us. And atopic dermatitis is quite a common condition, as Sandeepan sir mentioned. For so many decades, we know about the existence of this condition, but unfortunately, we don't have a robust data regarding the epidemiology of atopic dermatitis in India. So as a moderator, my job appeared to be very easy. For me, it appeared to be easy because I just need to highlight on few things. What is it? What COVID does to the atopic dermatitis? That's first thing to be understood. And then what atopic dermatitis does to COVID. So these are the things which basically includes in to learn today. And then we have what atopic dermatitis does to COVID, and atopic dermatitis therapy does to COVID. And finally, what COVID vaccine does to atopic dermatitis. So entire discussion will be on these 4 cornerstones. So we have had a wonderful presentation by Dr. Masters, and I think a lot of things have already been covered to some extent in the registry. So let me start initially with this particular question, which is very relevant. Is there any increase in the prevalence of atopic dermatitis in SARS-CoV-2 pandemic era? Are we seeing more number of atopic dermatitis? Let's see how is it in India. Dr. Godse, Kiran Godse, sir, could you please tell us what is your experience?
Well, very nice to be there part with the elite AD specialist. Well, there is definitely an increase of prevalence of AD, and what I see is the 3 things which 3 S's. One is sanitizer, second is soap, and third is excess hygiene. Half of our Indian people started washing 10 times a day using sanitizers and becoming more and more cleaner and cleaner. And that actually worsened as existing atopic, especially hand dermatitis was the commonest thing which happened. And definitely the first epidemic, 2020 was the worst, where people used to get lots of lesions all over the body, and then there was no doctor available. They used to buy something from the chemist and apply steroid creams, and then they used to come with us. So, well, the AD has definitely the effect on the COVID does worsen our AD, and 3 S's are important. Thank you.
Yeah, there was an increasing primarily because of what we did to COVID, what we did to ourselves during COVID pandemic. That's what Dr. Kiran Godse had to say. Dr. Srivastava,
Hello.
what is your experience in your part of India?
Yes, I think the prevalence of COVID-19, the prevalence of atopic dermatitis in relation to the SARS-CoV had increased. It is just because, and it has been reported from the US studies also, and which is a large cohort of the US studies that reported that there is the atopic flare with the worsening of the symptoms. And in their study, they have reported that the patient who of atopic dermatitis got COVID is around 4.2%. in comparison to the non-AD patient, which is around 2.8%. So definitely there is a surge of that. Still in India, we have to recollect the data and all to make this more authentic.
True.
But definitely there is increase in the prevalence. No doubt about that.
Thank you. Thank you for your input. As you say, as Dr. Kiran Godse just mentioned, there was a kind of obsessive compulsive neurosis kind of behavior with some of our patients with respect to, excessive sanitization and all. Doctors Phyllis Pulse, do you see similar kind of behavior among public, excessive use of sanitizers, soaps, washing repeatedly in your part of the world, in Netherlands or?
Well, thank you. Well, it's difficult to detect whether there is an increase of prevalence of atopic dermatitis, and we do have seen the irritant and contact dermatitis in patients with AD. We don't have data if it's more often, but we expect so. But the question is whether we don't see, if we don't have data, that the prevalence of AD is increased during COVID.
Yeah, more than prevalence, I'm not sure if the prevalence has increased, but Dr. Pradeep Srivastava just mentioned that prevalence has gone up. I think the manifestations have worsened primarily because of that. And that is how they are reporting to us. That's what Dr. Godse meant, I think. So the manifestations have worsened because of the usage of sanitizers. And that is how we are seeing more number of cases. Otherwise, they were basically fairly well controlled cases. And Sandeepan sir, you said you want to sit in backstage, but I don't think you can do that. What is your comment on? Because you see a large number of atopic dermatitis patients in your center.
Yeah, you must have seen that the secure AD registry, India's contribution is huge, and most of the contribution is basically on the registries by me and two of my colleagues, Dr. Abhishek De and Dr. Maitri Panda. So basically, we have, I won't say that it is the increase of atopic dermatitis per se, but yes, as Dr. Kiran mentioned very rightly, and Professor Phyllis also mentioned, it is more of a, because of sanitization, sanitizer use, overuse of sanitizer, more of irritant contact dermatitis. And some of the cases of irritant contact dermatitis, as we know, might have triggered the flare of atopic dermatitis. And this is quite well established fact. Because of that, probably. And second, as we know that atopic dermatitis is a disease which gets flare up with any kind of infection. That may be a Staph aureus infection, that may be herpes simplex infection, that may be a simple flu. So if COVID is considered as a flu, so it is likely to aggravate the disease or cause flare of atopic dermatitis. So we don't have difficulty in understanding that why there is aggravation of the disease of atopic dermatitis during COVID era in some patients. But overall, since we do not have data, compiled data, we cannot say that there is true increase in the incidence and prevalence of atopic dermatitis. That I fully agree with Phyllis.
Yeah, what I can, so just to summarize, probably there is no absolute increase, but I think there's more number of irritant dermatitis due to the overuse of sanitizer. And some of these patients with irritant dermatitis who have presented could be atopic.
Yes.
They may be atopic. That's what it appears to be.
True.
Yeah, and maybe what is related to maybe what you've seen in your practice is that in the beginning of the pandemic, we didn't know, and patients didn't know what would happen while using their treatment. So what we have seen also in psoriasis, that there was what they call risk mitigation behavior. People try to, on one hand, there is a group of patients that stop their immunomodulating treatment, which could end up with a flare of their eczema, because people didn't know in the beginning whether their use of their immunomodulating drugs was maybe they were more prone to get COVID, or whether the disease would be more severe. Luckily, that didn't turn out to be the case, as Dr. Musses have explained, and what came out of the survey. On the other hand, patients, what I mentioned, were changing their behavior, what they call risk mitigation behavior, that they try to avoid big crowds in the beginning already, that they were more protective than patients with no atopic dermatitis and with no immunomodulating treatment.
True. So that's another reason why there may be increased prevalence of atopic dermatitis. That's correct. Now coming to what atopic dermatitis can do to SARS-CoV-2. Is there a theoretical risk of acquiring SARS-CoV-2 infection among patients with atopic dermatitis? Dr. Mustas, what is the registry or what is your personal experience would say? Was there an increased theoretical risk of acquiring SARS-CoV-2 infection in atopic dermatitis? Are we seeing more number of COVID infection in atopic dermatitis as compared to other people?
That's a good question. Well, based on our registry, that's of course hard to say because you would need a healthy control group to really say if patients with AD are at a higher risk of getting infected with COVID. But like I mentioned in my presentation, there has been an epidemiological study using electronic healthcare records, and that study demonstrated that many inflammatory skin diseases, including AD, but also acne, psoriasis, and cutaneous lupus, were associated with a higher risk of COVID-19, also after controlling for confounding variables. So they may be at a higher risk, but like I also said, on the other hand, the treatments they may use could reduce the risk. So I think this is a question we can't really answer yet.
Correct. Yeah. Thank you. Yes, these are the ways to look at. And we really don't know unless without having looking at the relative risk. We need to control group. Without that, very difficult to say. Dr. Pradeep Srivastava, sir, what is your take on this question? Or maybe I slightly modify later on once you answer to this. Yes.
Yes. So there is an increased risk of the theoretical risk because there is an immunological hookup between COVID-19 and atopic dermatitis. I mean, there is immunological connect between these two. And the explanation for that is that in COVID-19 patients, there has been increase or higher levels of IL-13 and IL-4 have been found. And the things has been found in atopic dermatitis. So this atopic dermatitis patient might have predisposed to the COVID-19 infections. And second is that what COVID, these things two diseases go side by side, like atopic dermatitis, because most of the patients there are on immunosuppressants, so their immunity get dampened, they might get chances of contracting COVID-19 infections. And because of COVID, because it is a lot of psychological stress between the patients in the form of anxiety, the fear, and the depressions, and most important is the uncertainty regarding what is happening. So that psychological stress again increases the atopic dermatitis. And it's responsible, as we all know, the stress is an important factor in increasing this atopic dermatitis. So it goes both ways.
Yeah, I think, they are valid points. I'm not sure whether we have good amount of data to support it, but definitely, they definitely, as you said, the IL-13 increase could actually parallel the pathogenesis of atopic dermatitis. Sandeepan sir, you have, Dr. Kiran Godse, yeah.
Yeah. I thought, at one stage, exactly 2 years back, July 2020, our hospital was declared COVID hospital and more than 800 patients were there with us. So we could actually find out who are the ones who are going to get COVID. Regarding the rest of disease, those patients who had diabetes, hypertension, obesity, and those are immunosuppressants. These 4 criteria dictated who will get COVID. And most of our AD patients were on methotrexate, so they fall into this. But again, what dictated more was, I think, uncontrolled hypertension, diabetes, asthma, and obesity. So these 4 factors actually dictated who will get. So all the patients with skin diseases or without skin disease, if they got any of these 4 factors, they definitely would used to get AD, and that was our observation. Thank you.
Yeah, thank you. Thank you for that wonderful input of your center with respect to what is your experience in your center. Now, I would slightly modify this question. Do you think the atopic dermatitis patients will have more severe manifestations of SARS-CoV-2? Now, definitely, I would invite Dr. Schulz. What is your opinion on this?
Yes, well, the overall risk of COVID-19 complications appears to be low in patients with atopic dermatitis, and especially the ones treated with the immune modulating therapies. So as we have seen in the presentation, the highest rates of hospitalization, as we took hospitalization rate as the way to express the severity of the disease, because there were no deaths. Was the highest among the patients that used systemic corticosteroids and the highest among the patients that used combination of systemic therapies, including steroids. So that is in general what we have seen. And there are some groups of patients that are treated with monotherapy with dupilumab or methotrexate that are associated with lower risks of hospitalization.
Yeah. Sandeepan sir, what is your take on this? You also see a lot of cases of atopic dermatitis, whether they are at higher risk or are they at a more severe disease, risk of developing more severe COVID?
I mean, if I have to give a corollary of COVID and atopic dermatitis, I would say this is a chicken-egg relation. You know, one is which one is responsible for which we really do not know. I think we need to have more data, more research into it. But by and large, you know, this secure AD registry, as you know, Professor Phile said, very.
May I ask a question? Is in relation to this? Are many patients in India still treated with systemic corticosteroids?
Methotrexate, even cyclosporin also. There was not much aggravation of the COVID. Because we know that one of the, you know, there is a lot of, you know, hype, in fact, a lot of panic about use of cyclosporin. As, you know, Professor Phile said that one of the reasons of increased incidence or severity of atopic dermatitis was because many people, out of panic, they stopped their cyclosporin. This happened with many of my patients.
Right.
They themselves, either themselves or by their physician's guidance, they said, oh, you have COVID, you have to stop the immunosuppressive cyclosporin. And they came out with more severe disease.
Nice.
Yeah. So I have been telling this to many of my colleagues and juniors that we have to remember that for, you know, cytokine storm, one of the best drugs is cyclosporin actually. So, and this is the recommended treatment for cytokine storm in COVID. One of the recommended drugs for treating this cytokine storm as per American Journal of Pulmonary Medicine is cyclosporin. So cyclosporin is not all that culprit as it is thought to be. So there are many more ramifications of it, many more implications into it. And the matter is not as simple as it appears to be. And as we have seen from the secure AD registry, except corticosteroid, other immunosuppressants did not contribute to the severity of the disease. Rather, they maintained the disease under control, as well as the COVID under control.
Yes, sir. I think to take it forward further, it looks like probably we are not sure whether there is an increased theoretical risk of acquiring COVID infection in atopic dermatitis, but people who discontinued their immunosuppressants and all, they would have had a more severe disease because they were not able to control the storm, the cytokine storm. That's one thing. There was one question from Dr. Spulz. Sandeepan sir, probably you could answer best. Are we still using in India a lot of systemic corticosteroid in managing atopic dermatitis?
Yes, I must say the answer is yes. We are using. But you know, we are using it very judiciously, not very small children. And here I would like to say that, you know, as I said in Bangalore the other day, honestly speaking, we are using systemic corticosteroid because nothing really works to control acute flare of atopic dermatitis as fast as systemic corticosteroid. It works within 48 hours. Cyclosporin takes 3 to 4 days to work. So you can give a short course, judicious course, when there is no comorbidities for corticosteroids. And this has come in our publication where Professor Phile is also a co-author. I am also a co-author for International Eczema Council and British Journal of Dermatology in 2019. Use of systemic corticosteroid judiciously for acute flare of atopic dermatitis. Am I right, Phile?
Yes, I fully agree. We still have to use sometimes a short course of systemic steroids. And I must say, as a treating dermatologist in my hospital, I was a little scared when the results came out, whether we should still do that during COVID or when there is an if it's true that the pandemic is still not gone, whether we have to be more careful and patients could better suffer from a little longer their flare of eczema compared to using systemic steroids. And help to reduce the atopic dermatitis by introducing the more modern medicine like dupilumab of the JAK inhibitors.
Yeah, I think we have had a good discussion on this. What atopic dermatitis did to COVID. That I think fairly well discussed. Although we can't say something for sure, but it looks like there's no need to panic if a patient is on immunosuppressant. That's first thing. But however, my next question is, do we still have major concern after having gone through? Dr. Kiran Godse, do you think you still have concerns, certain concerns while managing atopic, especially with respect to usage of immunosuppressant in the patient in this COVID era?
Yeah, definitely. When there are COVID endemic zones, like typically the government declares zone where there are high endemicity. So there I don't give very high dose of cyclosporine. I give lower dose, say 1 to 2 mg only. And even methotrexate, I don't give higher dose on lower side only, because I know the more immunosuppression is more likely to fall to prey to COVID. And as I already told you, the 4 comorbidities dictates who will get COVID. But well, these 2 immunosuppressant, that is what we use maximum. I keep it at the lowest possible dose and not the full dose. Maybe the effects may not be great, but then at least I am not giving a complete immunosuppression to this patient. Thank you.
Well taken. Basically, your concern in patients with other comorbidities as well, like obesity, diabetes,
yes.
Especially keeping in mind. Otherwise, if a very healthy person, otherwise, do you think you should really need to reduce the dose of cyclosporine also?
Yeah, especially in Bombay, which is thickly populated, and there are some zones where they declare that this is a hyperendemic zone where there are almost 5% of people affected. So there I'm really bothered. I would not like to give a higher dose. Well, otherwise, you can give full dose, but in such situations where the containment zones are declared in Mumbai, so typically I used to see that in zones and then I used to dictate and give a lower dose for such patient. Otherwise, full dose is allowed, no problem.
Yeah, but actually the discussion is going this way, that if you are giving actual immunosuppressant, they may not have a severe disease.
Yeah, but that is the opinion. What I feel is for cytokine storm, cyclosporine work. Cytokine storm everybody doesn't get. To begin with, how you fall prey to COVID is your immunity, and what immunity dictates is we all know that all these matters, including comorbidities and whatever he's taking. So that's why I'm a little worried.
Yeah. Now, definitely, I have to invite Dr. Spills once again. So do you think we need to have a lot of concerns while treating atopic dermatitis patients with immunosuppressants?
Well, no, currently the data show, and it's similar in other inflammatory diseases, that we do not have to have concerns. Only, I would say, be very careful with combination of systemic steroids and another immunomodulating treatment. But for the rest, I would say maybe better to treat it properly than not.
Yeah, I think Dr. Musters also in her presentation, she did mention, correct, Dr. Musters, that if there are more than one immunosuppressant, the chances of hospitalization was higher.
Yes.
Yes, that's correct.
So I think, you need to be still careful while using it. Dr. Kiran Godse opened his remarks with this sanitizer. In India, you have wonderful, colorful. I think it must be the same thing in rest of the world. We have very colorful ones. In fact, to an extent, we've also, I think healthcare workers were using a lot of hand sanitizers and the very good, colorful ones. And in fact, sometimes I happen to see some strawberry juice or something, I suddenly feel like taking it and putting a few drops on my hand and rubbing my hands. So that kind of, so much of, compulsively we are doing this. I think it's still continuing with us to some extent. Yes, Dr. Godse, I think you since you took up this, how do you tackle problems associated with
during 2020? During the first wave, it was so difficult for people to stop using them. And typically, most of people use it every 1 hour, every 15 minutes. So what I used to tell them to wear cotton gloves or wear disposable gloves and do the work and throw it away, because more 99% alcohol you're putting every 5-10 minutes on the body is obviously those atopic or those who are sensitive patient, they used to get worsening of their hand eczema and obviously full body eczema. So that were a few things we should tell the patient to use barrier methods rather than using the sanitizer or alcohol.
Yeah. Dr. Srivastav, is that in India, it's all or none? People who use it excessively. Then you have other category who will never do any of these precautions.
Yes, you are right on this. And regarding this original questions, the various groups of eczemas like European Task Force for Atopic Dermatitis or IACI or International Eczema Council, they all reinforce that the skin is an important blueprint for controlling this and minimizing this atopic dermatitis. And what they have suggested that in spite of using sanitizers, one must use soap, which is mild and gentle and non-allergenic, and soap and water. These things should be practiced, and sanitizers should be avoided as much as possible. And after patting after cleaning the hands, one should apply the thick layer of moisturizers over there so that this flare-up can be prevented. So these things has been supported by various this eczemas group.
Yeah, I think wonderfully mentioned. So yes, use a non-allergenic or milder soap instead of sanitizer, especially in high-risk people like those with hand eczemas and atopic dermatitis, dermatitis. And we also have a lot of people with the contact dermatitis, like cement contact dermatitis and occupation-related dermatitis. So they are the patients. I think you have nicely, some summary has been wonderful. Now we'll get into the next domain of discussion, that is atopic dermatitis therapy. Now, I think probably I'm not sure if this question should be asked at all, but still I think I should ask. I'll invite Sandeepan sir. Sir, is there any difference in the choice of topical therapy if you in this COVID era? Or we don't have to think much about it?
I think your second statement is correct. That we don't have to modify our protocol of topical therapy
at all
for atopic dermatitis, thinking in about the COVID. It does not make any difference, right? So as we go for topical steroid followed by topical tacrolimus or a sandwich therapy, then stopping topical steroid, continuing tacrolimus as a maintenance treatment, and throughout using moisturizers. The same protocol should continue with the COVID also.
So important message here we are giving is you don't have to worry much about when you are using a topical therapy. Probably you don't have to modify at all in atopic era or COVID era or otherwise. You probably would just give what the patient deserves rather than looking at the COVID era. So the message is very clear. You don't have to modify your topical therapy. Sir, how about systemic agents? In India, we do have certain restrictions. We don't have easy availability of the dupilumab, and we still are, because drugs like the JAK inhibitors are expensive, and there is concern about its usage. Cyclosporin is also quite expensive in India. We often use a lot of other drugs like methotrexate, which are less. So it's a different kind of situation in India as compared to probably many other countries where all the therapy is taken care by the government itself. For the patients. In India, they have to buy from their own pocket, most of them, many of them indeed. So do you think there is a concern about usage of systemic agent, or do you think this drug I would avoid in COVID era, any particular drug?
Since you have mentioned about the Indian scenario, that's why I'm responding to it. I think as I have mentioned earlier, by and large, apart from systemic corticosteroid, for cyclosporin, we have adopted a policy that if the person has acquired, COVID infection, avoided cyclosporin for 2 weeks after recovery, then we have reinstituted cyclosporin. This is one. And for vaccination of COVID also, prior to vaccination, 2 weeks we have avoided cyclosporin. Right. So this is the protocol we have followed, and we have got good response. And as far as the dupilumab is concerned, we have published the first study of dupilumab. All of you in Indian Journal of Dermatology, those small number of patients. only 25 patients, because the cost is exorbitantly high in Indian scenario. One injection in Indian rupees come to 56,000 rupees, 300 milligram pre-filled syringe. So, cost is definitely a limiting factor. But as you have seen, Dr. Anili has very categorically shown that in the secure ID registry, dupilumab has been found to be the safest drug during the COVID. Even if the person has active COVID, only one drug which you can continue, and that is dupilumab. A person who has severe atopic dermatitis, rather than letting him suffer from the disease, the one drug you can continue is the dupilumab. So that has come out of this, very important registry.
Yeah, there's one question from the audience. I think I should take it up. It's a simple question. Which antihistamine is better to be used in children? I'm not sure if it is concerned with COVID era. Dr. Srivastava, would you like to take this question? Any concern with antihistamine in COVID?
Yes, I don't find, and I don't think there is a concern regarding antihistaminics. It solely depends upon how much sleep is disturbed of the patients. If the sleep is disturbed in quite amount, then it should be a sedative antihistaminic should be used. Otherwise, the second generation antihistaminic will do the work.
Okay, yeah. I think, yes, I don't think we need to discuss further on this aspect. I think we have had this discussion on the systemic agent. I'm still continuing. Now, I would direct this question to Dr. Spulls. Do you have concerns in giving any systemic agent in atopic dermatitis at present? Today, you would treat what patient deserves, right?
Yes.
Don't think
I
at
agree.
all about COVID.
Yeah. Only what I mentioned before, I repeated that the combination of steroids together with immunomodulating, I would be careful about that. But even when it's necessary, it's also case by case. Depends how much a patient suffers, and if you don't get control of your atopic eczema, and that is the most important complaints. I would even try with the combination, but very careful. And when there is a severe COVID infection, of course, I hand over to internal medicine doctors, and they have to decide together with us.
Right. So just to make it a little more in a scenario basis, I'll direct this to Dr. Srivastava. This is a typical happening. It can happen to anybody who is practicing. Patient age 12 male from a COVID containment zone reports with moderate atopic dermatitis. Score is approximately 40. Previously treated with the emollients, topical corticosteroid, topical calcineurin inhibitors, and antihistamines with no good response. So what is your management now, Dr. Pradeep Srivastava? So this is for the audience. So they may come across such cases. Yeah.
Yes, as I already mentioned in the questions that TCS and TCI with this there is no good response. I think the still of not having good response, the emollient should be continued in the patients. And if at all we have to introduce the systemic immunosuppressant, that is traditional immunosuppressions like cyclosporins or corticosteroid, that should be at a minimal effective dose. That has to be introduced. As already been discussed, that a short course of corticosteroids to control the initial tear can be tried. And after that, it should be shifted to the minimal effective dose of the cyclosporins that Dr. Sandeepan has already discussed. So my take will be like this.
Yeah. Dr. Masters, what was the usage of systemic corticosteroids in your registry? Was it very frequent in...
You mean how many patients were... let me check the exact number. We had... in total, there were 7 patients only on systemic corticosteroids and 14 patients on combination, so 21 patients in total.
Yeah, thank you. And those combination patients at high risk of hospitalization, that's you have mentioned earlier. Yeah. Thank you so much. So corticosteroid usage has been very less, isn't it? Systemic corticosteroid, considering the number of patients, just 7 and another 14, maybe 21 patients. So number is very less. So that means it's not among the favorable drugs. I think it is used in short courses. That's
Yeah, in children, there's a direction in using more often methotrexate in younger patients as well for atopic eczema, although it's off-label, compared to cyclosporin. Initially, everybody was using cyclosporin, but there's more direction to use in younger children methotrexate first,
okay.
and also at the lowest effective dose. And if it's not working, then maybe continue to cyclosporin or even to the new biologic treatments.
Yeah, dupilumab. Yeah, that's nice. And now I will just
Hello,
go
Dr. Manjunath.
yeah.
I can I ask one question from the board members regarding the role of apremilast in treating the atopic dermatitis during COVID.
Yeah.
Any input from any of the board members regarding apremilast?
Yeah, Dr. Spulz, do you use it in Amsterdam? Apremilast?
Well, we use it not for atopic dermatitis. We do use it a little bit for psoriasis, but not so often. And actually, in my practice, I don't use it at all because I only get the more severe cases. And I think I have more active biologics for treating psoriasis with other drugs, with the biologics instead of the small molecule, for a good result. Yeah.
Yeah, I think that's yet another drug. Probably you don't have to worry too much, whether you are in COVID era or otherwise. You can probably use that drug. That's what I think. If it works, of course, that's always
because in the leukocytes of the atopic dermatitis, the phosphodiesterase 4 inhibitors, phosphodiesterase 4, this has been found.
Oh,
So I thought, is there any role of this in treating that?
Yeah, that's right, sir. Yeah.
प्रदीप ने बहुत ज्यादा पढ़ लिया है actually.
नहीं sir, this is all your I mean
This is no, I'm just on a lighter vein. I was saying you have gone too much into molecular level. All these things are not you cannot always extrapolate into clinical
Right.
response of the drug.
Right.
Apremilast I have used couple of children, older children in atopic dermatitis. I would say maximum 5-6. Result is not at all encouraging. It takes very long time to show the response, and the parents become very much anxious about it. That the drug is given and they are not seeing any visible response in terms of pruritus and the eczema lesions. So since then I have abandoned because there are a lot of other alternatives which are fairly good.
Yeah.
Thank you. Thank you.
Yeah. Plus, you give a headache and a loose motion.
Yes.
That's also there. Yes. Sir. Now, this difficult question to Dr. Kiran Godse. Same patient, the one we discussed earlier, was treated with cyclosporin and 2 weeks, and he diagnosed to have SARS-CoV-2 with mild symptom. So, what will you do? Because containment areas are very, very common in Mumbai. I'm sure you will come across such.
We have. In fact, on my floor there were 4 patients. That's the kind of thing we had at that time. But typically, in what our pediatrician and physician used to do, they used to stop cyclosporin because cyclosporin is only used in a cytokine storm that every patient doesn't get.
Yeah.
Cytokine storm you get only out of 10, 2 patients used to get, and IL-6 and IL used to dictate. We used to do IL-6 every second or third day to find it out. So typically, standard treatment with stoppage of cyclosporin was advised by most of our physicians and pediatricians, and that is what I follow.
Yeah, what is your take here? Suppose diagnosed, so you'll discontinue cyclosporin.
Yeah, I'll discontinue.
Yeah, I think that's a message for all those who are observing. And what would be your management? He's having a moderately severe atopic dermatitis.
Yeah, so just emollients and
yes.
he can use.
But some amount of flare could happen, but I think that has to be accepted, and then try to reinstitute the treatment depending on how the patient does with the COVID.
Right. And during the first wave, because I have got a lot of these patients we used to see, most of the patients were used to treated with solution methylprednisolone IV or oral. So the atopic used to come down when patient was on treatment for COVID. And once they stopped treatment for COVID, they used to worsen because the Medrol used to be given for 3 to 5 days for most of our patients.
Yeah. We discussed well on steroids. I would take the next question. Dr. Spulz, are you using tofacitinib and baricitinib, and how frequently and in this COVID era? And do you have concerns? Yeah.
Well, actually, tofacitinib we don't use for atopic dermatitis, not registered for that indication. Baricitinib is registered since, I think, maybe 3/4 of a year. We do treat patients with baricitinib, but not many yet. We are increasing the number of patients using JAK inhibitors. We also have upadacitinib and abrocitinib available. The good thing about baricitinib is that it is that we have some long-term safety data because it's used in rheumatology already. So that makes it that you feel a little bit more safe. And the other good thing about baricitinib is that it's also investigated as treatment for COVID-19, which shows good results. So it might have benefit in both ways.
Yeah. Sandeepan sir, what is your experience with JAK inhibitors? See, in India, we use tofacitinib because now we have generics available. It's become less expensive. If we have to use the originator, then it's expensive. Baricitinib is very, very expensive in India. So what is your experience in India using these drugs?
Yeah, before I share that, I must inform all of you. I think this is heartening to note even after more than 3 years of webinar, when there is webinar apathy amongst people, more than 600 participants have logged in for today's seminar.
Thank you.
This is a great. I think this is because of Professor Files and of course Dr. Anneli. Thank you very much for your presence. So many people are really and the topic itself. And Dr. Manjunath, you are steering the panel discussion wonderfully. And Dr. Kiran and Dr. Pradeep are giving wonderful feedback. And all because of that, these people are so much interested. They have still logged in more than 600 people. I didn't expect that many people will log in. I didn't expect. I mean, honestly speaking, I never thought that 600 people will be logging in today.
Yeah.
And it's
10 p.m. now, no? It is already 10 p.m. So it is actually bedtime for most of our patients and most of our doctors.
Yeah.
Very nice. Congratulations.
Yes.
Yeah.
Now
regarding the use of JAK inhibitors, tofacitinib, though it's not recommended as per US FDA, but since we have tofacitinib available and we are lucky to have it at a much cheaper cost in India, and mostly though it is being marketed to the rheumatologist, but a lot of conditions, psoriasis, people are using tofacitinib. I have started using oral tofacitinib in psoriasis patients, in patients with atopic dermatitis also, but definitely with proper judiciously selected cases and with proper monitoring, keeping in mind about hyperlipidemia and then cardiovascular risk and the thromboembolic risk. All these parameters are being monitored. And I must say that the initial result, whatever I have given 20-25 patients, has been encouraging. This I shared in one of the session. Files will be happy to know that during SPIN, and people were really interested to know. I said that though it is not recommended as of now, but maybe in future that USFDA will also recommend oral use of tofacitinib.
Wonderful. Thanks for that input, sir. And we have one question. I think it's probably not related to COVID. This is from Dr. Rajat Das. Do we need to avoid food? If the previous webinars were attended and all this was discussed in detail, Sandeepan sir, you could quickly tell for anything food, because this is a question from the audience. Do we need to avoid food for atopic eczema, not the food allergy associated?
By and large, if you the blanket dietary restriction has got no role in the treatment of atopic dermatitis. It has been seen unless and until there is a temporal correlation, and that is best elucidated by oral food challenge. With the very utterance of the oral food challenge, I have seen many of my dermatologist colleagues, they become panicky that oral food challenge is a big thing. Not very big thing. You can ask the mother that what are the food items, shortlist 4 items, and you can start giving only one and avoiding other 3, and see it for thrice after every 3 days. So total, it takes 4 months time to identify what food items are actually incriminated. and accordingly you can decide. And this is not, the great recommendation by the god of food allergy and atopic dermatitis in the world, Professor Hugh Sampson from Mount Sinai, New York. So he has done the largest cohort of food allergy and atopic dermatitis. And this is his saying, what I am quoting to.
Yes. Thank you, sir. Thank you on behalf of the person who asked the question and from the moderator. Now we are moving to the last part of the discussion, sir. We are already, I think we are 10 p.m. So we'll just take one last part, that is COVID vaccine and its implications.
So the discussion is going so interesting and so many people are interested. I think maximum 5 minutes we should go.
Yes, sir. I think this will be the last part of discussion, sir, regarding vaccine and its implication. These are the vaccines which are available in India. Sputnik, not just approved, it's already available and people have taken a Sputnik as well. And Covishield and Covaxin, the Indian vaccine, that is Covaxin, is also in use. Now coming to a good discussion on, have you seen increased incidence of severity of atopic dermatitis in patients with COVID vaccine? Srivastava, sir, what's your take on this?
My take is that that AD is not a contraindications to the vaccinations.
Yeah.
Because it doesn't cause the worsening of AD, as it is a Th1 skew. So it doesn't cause the worsening of AD. But and second one important thing is the risk-benefit ratio of getting COVID vaccine is much better than what of the risk of acquiring this COVID infections. And the third important issue is if the patient is on a broad or the traditional immunosuppressants, then certainly this they can attenuate the effect of COVID vaccines. So that has to be dealt with judiciously. That Dr. Sandeepan has already mentioned about it. Stop 2 weeks before all these things. As far as dupilumab is concerned, there is no attenuation of COVID vaccine has been observed, has been reported by groups. So that can be continued. Again, if the patient contracted with COVID infection, it has to be stopped for the 2 weeks and then continue. This is all regarding this.
Yeah, Dr. Masters, do you have any data regarding vaccine and COVID, its implications?
Well, Dr. Spils and I are also involved in another study that was conducted in a lot of hospitals in the Netherlands. And that study showed that, for the vaccine response, also a lot of immunosuppressive drugs were not associated with a lower response to the vaccine, only rituximab and MMF. So, and for the increased disease activity after vaccination, paper is coming up about that as well. That study group, they looked at the incidence of increased disease activity in patients with immune-mediated inflammatory diseases after COVID vaccination. And they found that self-reported increased disease activity after vaccination was recorded in only a minority of patients. And for atopic dermatitis, together with systemic lupus and ulcerative colitis, self-reported increased disease activity was least frequent. So, we can say that COVID vaccination does not affect the disease activity of patients with atopic dermatitis.
Thank you so much. It's a wonderful data and it's a very crystal clear message. So there should be no reservation in giving vaccine to atopic dermatitis patients. That's what it would say. Dr. Kiran Godse, we have seen pityriasis rosea, we have seen urticaria, we have seen vasculitis, whatnot. And what about atopic dermatitis? What is your experiences? Do you have a higher number of players in vaccine era?
Yes. See, I'll be very clear. Those who have got more than 10% of body area involved, those patients with AD or any skin disease with more than 10% body area involved, when they take vaccine, I have seen worsening of their disease. So typically moderate to severe disease may worsen, especially for few days where you need to give short course of steroid, it subsides. But obviously it's not a contraindication, but there are few patients who worsens after taking vaccine, but it can be easily managed in 2 to 4 weeks with good use of topical steroids and antihistamines.
Yeah, I think we have had a wonderful discussion, but vaccine is something, whether COVID era ends or not, I don't know. But vaccine era is not going to end for another decade, I'm sure, for various reasons. So we will listen to Dr. Sandeepan Dar and Dr. Dr. Spulls. Then we can probably close the discussion. Sandeepan sir, first you, what is your take on vaccine, atopic dermatitis?
By and large, the vaccine is not contraindicated in atopic dermatitis. That is one thing. And, as Dr. Anneli very categorically mentioned, strictly no are two molecules, MMF and rituximab. Others can be given. Dupilumab is the safest. And as far as the vaccine and aggravation of atopic dermatitis, I have seen few patients of atopic dermatitis. They had aggravation after vaccine. I think that is more because of psychological stress of thinking that they are getting the vaccine rather than the vaccine itself. Like many patients with urticaria, they started calling me, "Doctor, we have got a chronic urticaria. Should we take vaccine?" I'm sure that Kiran must have received thousands of calls. So the same thing happened with me also. Many patients with atopic dermatitis, they started calling me, "Doctor, can we take vaccine?" Nothing happened to them actually. I told them, "You go, safely go ahead." And as Dr. Kiran has very rightly pointed out, in few patients, they had acute aggravation, which can be controlled by a short course, 7 to 10 days of oral corticosteroids. So why not to give? So that was our policy by and large. Now over to Phyllis. Yes, Phyllis.
Yes, we do not see severity of eczema under vaccination. I think the most important now is to see whether patients that are still using systemic immunomodulating treatments have the same antibody formation against COVID as patients that are not using systemic immunosuppressive. And that is under investigation currently. The idea is that patients on immunomodulating treatments may have less resistance to COVID, so they might be prioritized in getting COVID vaccinations again in the fall here in Europe.
Yeah, thank you, Dr. Phyllis. I think with this, actually, we have discussion on COVID and atopic dermatitis, but there are 4 questions, may not be related to, I think we have to, for the people who've been waiting for such a long time and listening to this webinar and watching it, I think we would cover these 4 questions. The first question is from Dr. Hariharan Krishnan. Sandeepan sir, this is your topic. Do topical probiotics have role in treating eczema?
As of now, it is very difficult to say because we do not have data. But maybe, as you heard in the last, I'm sure you have heard in the last discussion, last international webinar with Helen Alexander from St. John's Hospital, St. Thomas. She also mentioned that there may be a role, but we do not have data as of now.
Yeah, I think that's the answer, Dr. Hariharan. I'm sure you're happy with that. Now, this question too, because I see IgE here. So, Dr. Kiran Godse, role of IgE in atopic dermatitis, and it's how important is Scorad and its application in daily practice?
Yeah, we tell the patient it is allergy and we don't investigate. So at least IgE is a good tool to tell the patient, "Tumhare khun mein allergy hai, there is an allergy in your blood." So you do it, but don't follow it up. Don't track IgE. It is not to be tracked. But IgE is to tell the patient that, look, there is something wrong in your blood. You need to take medicines for a long time. And that's all. But don't use IgE. People keep on using it again and again, testing every 2 months to find out whether it's come down. That should not be done. But a basic CBC IgE level should be done to understand the disease, to understand the allergen exposure to the patient, and accordingly plan. But that's all. But don't take it further. Thank you.
And it's a minor criteria for your diagnosis of atopic dermatitis. If you're a strict, disciplinarian following the criteria for diagnosing it. And the third question is from Dr. K. Sridevi. Pradeep sir, severity of disease of known atopic patient during pregnancy. So what is your take on the pregnancy atopic dermatitis and management?
So I don't have any idea regarding this. I cannot answer this question. Sir. I think Dr. Phyllis can answer this question.
Yes, there's a good paper from the ETFAT group in the European Task Force Atopic Dermatitis in treatment during patients that are willing to become pregnant under lactation or are pregnant. I think the main message is that, topical steroids are safe, systemic steroids are safe, cyclosporin can be continued, And if that's not possible, and it's still severe disease, even azathioprine could be an option. Do not have personal experience with that, but I know it's used in other countries. And we are slightly changing our vision on whether we should stop dupilumab for patients that are using it if they are willing to become pregnant. Maybe and that is from the pulmonary disease doctors, they say, well, we continue dupilumab in the first trimester when somebody is trying to conceive. Continue dupilumab. When somebody gets pregnant, maybe after the first trimester or in the first trimester, stop your dupilumab, and then hopefully the patient is under control until the end of the pregnancy, and you restart again after giving birth, and maybe after lactation. Yeah. So that's not official yet in guidelines for atopic dermatitis, but it's slightly things are changing now. But initially, it is to avoid active treatments, if not possible, topical steroid, systemic steroid, or cyclosporin, or UV light, UVB, narrowband UVB treatment. That could also be a very good solution for pregnant patients.
Yeah, thank you, Dr. Fides. Yeah, cyclosporin is okay. Azathioprine probably, if nothing else, yeah, you can still think about it. And dupilumab, you mentioned, if you can avoid it in the first trimester, and then probably yes. And that's how you can manage, yes.
Or you can use it in the first trimester, but avoid it in the other trimesters.
Yeah. First trimester, you can use it. You try to avoid in the other trimester. So that's the way it is. And finally, Sandeepan sir, fungal infection when superadded in atopic dermatitis. How do you manage? The fungal infection is there everywhere, sir, now in India. Yes.
Basically, on a
question, and I think with this we can stop the discussion.
Yeah. Yes. First question is when the atopic dermatitis or eczematous lesion has a superadded fungal infection. As I said the other day, that it is you can just give topical emollient, not topical steroid, and you can give oral antifungals. And if you are giving cyclosporin, stop it. You give itraconazole. And the fungal infection will go in 2 weeks' time or maximum 3 weeks' time. You can restart cyclosporin. In the meantime, give just emollient. Don't give topical steroid. That will complicate the fungal infection. That should be the policy.
Yeah, treat the fungal infection first. Then, that's something which is curable.
And something which is of acute onset.
Yes.
And the atopic dermatitis is a chronic disease, and it can wait for some time.
True.
That is the message.
Yes, sir. I think we had a very good discussion, and thanks a lot. It has been a wonderful learning session in the last 1 hour or so. Thank you, Dr. Files, Dr. Masters, Dr. Srivastava, Dr. Godse, and thank you, Sandeepan sir, providing this opportunity with this SES platform.
Thank you. Sorry. I think I must thank Professor Files profusely. Because the moment I approached her, she immediately agreed, and and Dr. Anneli for agreeing to present the data of a very important registry, which is going to create waves in future. I am sure it has just started with one publication. I think it will have multiple publications. And thank you very much, Professor Files and Dr. Anneli, to join our SES platform and enrich us. I sincerely thank our erudite colleagues, Professor Kiran Godse, for giving very important input. Dr. P.K. Srivastava for excellent discussion, taking it forward and giving very important pathogenetic mechanisms and detailed molecular thing. And last but not the least, a wonderful panel discussion moderation. As I always say, Dr. Manjunath Sinha is one of the finest moderators I have seen. And that's why very important sessions, I always, keep him as a moderator. Thank you very much, Manjunath, for doing a wonderful job. And on behalf of entire SES team, I sincerely thank all the participants and all the faculties for joining today. And I sincerely thank our Chief Coordinator, Mr. Tapas Kayal. And last but not the least, our sponsor for today's session, not only today's session, for our academic endeavor in Society for Eczema Studies. A huge support we are getting from Alchem Dermachem under the leadership of Mr. Raman, Mr. Deves, our own Kallol, they and entire team of Alchem Dermachem. Sincere thanks to them. Thank you very much. Good night from India to Fairis and Anil. And good night, everybody.
Thank you so much, Sandeepan, for inviting us. Thank you so much, all of you who are attending. Thank you.
Thank you.
Bye.
Recording
Thank you,
stopped.
Sandeepan sir, for giving us the opportunity.
Thank you very much, Davis.